Good morning, everyone. I am Snigdha Pusala Vidyasagar. I am an associate professor of medicine at the University of Minnesota Medical School, and I practice sleep medicine. And we have a fellowship program with fellows at the Hennepin County Medical Center, rotating through VA as well as the university site. Welcome you all, and also I wanted to tell you something that I'm so glad that you all chose this path of sleep medicine as your career path. I have a lot of passion about it, and I'm glad that you all have chosen that path of sleep medicine because it's a great field. Still so much to unravel and so much of research opportunities. So welcome you all, and I am going to talk to you today about sleep disturbances in menopausal women. I'm going to be focusing on some of the salient symptoms here and the disturbances that occur in this group of women. And I will also have some time towards the end of my talk open for any questions that you may have, and I'm happy to answer. But I think we should have plenty of time for me to be able to answer the question stuff. But if you happen to come across any question and there was no time, Sally will give you my email address, and feel free to contact me via email, and I'll be happy to get back to you. I do not have any financial relationships to disclose, and I will be discussing some off-label use and or investigational use in my presentation, because I'll be talking about some things about the pharmacological aspects of insomnia management among this group of patients. So the learning objectives of today's talk are to promote an understanding of the challenges and changes that happen in sleep during menopausal transition, reviewing the common sleep disorders that occur in women of the menopausal age group, and to review treatments for the common sleep disorders during this menopausal transition. So menopause is a natural process that occurs in women's lives as a part of normal aging. And at any given point in time, women often have been shown in surveys and research studies to present with more sleep disturbances, particularly insomnia, compared to men. And the prevalence of sleep disturbances increases both with aging in men and women, but they are more comparable to men among the women, particularly in this menopausal age group. And the prevalence of the sleep problems also increase during this transitional period where the woman goes from the perimenopausal changes to complete menopause. That can be a period, can range anywhere from 7 to 10 years, because the hormonal changes with the menopause precede the actual menopause by 7 to 8 years on average, sometimes could be longer than that. About the historical perspective, there's quite a busy slide here because you will see some interesting things. I found them all very interesting. It was Aristotle who referred to age at menopause being about 40 years, but again, this was so many years ago, right? Charles Pierre Louis de Grandin coined the term menopause way back in 1921. So we're talking about 200 years ago. The general medical interest in menopause increased considerably in the mid-19th century. In fact, when you look into sleep disorders in women, until the early 1990s, most of the research studies were all focused in sleep in men. There weren't that many studies that were done in women. So the recognition and the awareness started happening around the 1990s, when there is more awareness and studies that have been available now. And now there is better understanding. Still, there's more to do, though, in terms of research work and understanding the problems among the menopausal women and women in general, for that matter. In 1930s, people started describing menopause as it is a deficiency disease. a deficiency of hormones. It was in 1970s that the first International Menopause Society was established. First International Congress on Menopause was organized in Paris, France in 1976. And October 18th is considered as the World Menopause Day, held every year. So a month from now, almost. Does anybody want to take a guess about when the estrogen was sort of like synthesized and the hormone estrogen? (1800), early 1900, mid 1900, early 2000. So it was in 1938 that it was first diagnosed and as a hormonal substance. So that also is pretty long time ago. There are various definitions for menopause. The commonest one that we are all aware of in medical school and even for general people too is cessation of menstruation due to degeneration of ovaries and follicles, accompanied by changing ovarian hormones, which are estrogen and progesterone. But the WHO, the World Health Organization, characterizes most specifically that menopause is a permanent cessation of menstrual periods, either natural menopause or iatrogenic menopause, which is surgical, total hysterectomy, or because of chemotherapy or radiation therapy. But the most recent menopause categorization is two ways. One is the menopausal transition, the other one is a postmenopausal period. Menopausal transition is defined as variable cycle length 7 days different from the normal cycle, or more than 2 skipped menstrual cycles and an interval amenorrhea of 2 to 12 months. And postmenopausal is defined as more than 12 months since the last menstrual period. So this is the most current classification of the menopausal transition and the postmenopausal categories. Coming to the epidemiological aspect of the menopause and the women in general, the epidemiology wise, Western women mostly attain menopause between 50 to 52 years, but that is subject to variability depending upon the race, ethnicity, as well as the lifestyle factors. Supposing we take into consideration Asia or India for that matter, the menopausal age group would be commonly between 47 to 48 in those countries, whereas in the Western, mostly the American population, if you consider, it is between 50 to 52, commonly around 51 years. And the worldwide population, according to the census right now, there are 470 million postmenopausal women. And with the population increase, we are going to be expecting that to increase because 1.5 million women enter menopause each year. So the projection is that by 2030, they will be reaching at least 1.2 billion population. So it's very important that we really know as sleep providers how these women present their sleep problems and how we diagnose them and correct them and treat them. In the past, there was not much greater life expectancy beyond the first menstrual period, but now the studies have shown that most women live long enough and can expect to live at least another 30 more years beyond their last menstrual period. So what exactly is happening during menopause? The key thing that is happening in menopause is hormonal changes. And the hormonal changes are particularly some of these fluctuations can be dramatic in some women and can be gradual in others. So there is changes in the sexual hormones, estradiol, progesterone, and androgens as well. So what do these fluctuations happen? What do they mean? They are declining gradually. So when they are declining, they have implications not only on the menstrual cycle, but they can affect other aspects, which is behavior, mood, cognition of the woman. And they can also cause menopausal related sleep disturbances and disorders specifically. And we will talk more about the sleep disturbances and sleep disorders in the next few slides. So the loss of ovarian estradiol E2 leads to low E2 concentration in postmenopausal women than in midlife women of the same age category. And that is one of the factors that can explain why these sexual disparities occur in sleep disorders and even the immunometabolism of men versus women. Now changing the gear to what are some of the common symptoms these women present. It is important to know that not all present the same way. There are many women who go through the whole transition process with either few or no symptoms. But there are some category of women, a small percentage, who have severe symptoms that can interfere with their daytime functioning, whether it is at work or home or school in general. And these are the people that are we sometimes see in our sleep practice, even though some of them are also seen in a general practitioner clinic, internal medicine, family medicine, and all that also. In 2005, the National Institute of Health, NIH, had the State of Science Conference panel, the first one to report on menopausal related symptoms. And during that conference, it was declared that sleep disturbance is one of the core symptoms of menopause. So 17 years ago, so not too long, I mean, it is like not too long ago, like, you know, it's like the awareness has come lately in women, as I mentioned before. Most of the research studies all started happening after the 1990s. So what are some of the symptoms they present with? Hot flashes, night sweats, insomnia, which could be either difficulty falling asleep or staying asleep or waking up earlier than their desired time or not feeling rested when they wake up. Mood changes, anxiety, depression, irritability. Sometimes they can have poor concentration as well. And some women also present with some cognitive impairment too. But more than that, common is fatigue and excessive daytime sleepiness, particularly if they have an underlying sleep disorder. So what are some of the factors contributing to sleep problems in the menopausal women? Most of them are menopause-specific factors, which are related to the hormonal changes, decline in the estrogen and the progesterone. Whereas with aging comes the other array of issues with health, comorbidities, and physical changes in the body. And stress is another factor that can impact the sleep problems, just not only confined to the menopause age group, for people in general. Psychological factors, lifestyle changes, coexistent health conditions like we talked earlier, and some cultural factors as well. Caregiver responsibility is another thing too that can affect the sleep problems in menopausal women, because that is usually the time when they will be taking care of their parents or parents-in-law or other extended family members who are older while they are going through their own transition. And research studies have shown that at any given point in time, caregiver responsibility falls more on women compared to men. So while living with menopause, either the primary caregiver role or the work-life balance, underlying mood disorders, because with menopause, there is fluctuation in the hormones, and the hormonal fluctuations have been associated in some patients with depression and anxiety, more so with depression. Other medical comorbidities and coexistent sleep disorders specific to the menopausal age group, such as obstructive sleep apnea or insomnia or restless leg syndrome, and employment and voluntary work and other responsibilities. So vasomotor symptoms are very common because of the hormonal changes in the menopausal women that have been implicated in sleep disturbances, particularly the insomnia in these women. And there are two predictors for women who can be at high risk for vasomotor symptoms. Those are women who have high body mass index and those who attain menopause at a younger age, mostly surgical compared to natural menopause, because oftentimes the hormonal changes are very dramatic following surgical menopause with the total hysterectomy rather than the natural menopause that occurs over a period of years. And etiology, advancing age, coexistent underlying depression, other conditions such as fibromyalgia or hormonal factors all have been implicated in association of insomnia among these women. So the estimated prevalence of insomnia is pretty high, both in the peri and the postmenopausal women, ranging anywhere from 38 to 60%. There are so many studies that I've done, but I'm highlighting you the most important landmark studies. One of them is the one, I should have probably put this one first on the top. This is a study of women's health across the nation with the acronym SWAN study. This is like a very hallmark key study that has been done in women of this age group, where most of the information came out after this particular big study. In that study, they reported 38% of women had problems with difficulty sleeping between ages 40 to 55. Whereas higher levels of sleep difficulties were reported in women who were late perimenopausal, about 45%, and with surgical postmenopausal, 47.6%. So there's a little high increase in patients with the surgical postmenopausal age group. There's another study that was done in Ohio it's a Ohio midlife women study, and they found that in women ages 40 to 60 years, troubled sleep or disturbed sleep was reported in almost 54 to 58% of the women, which is more than 50%, which is pretty big. Wisconsin sleep cohort also found that perimenopausal women and the postmenopausal women are 2 times as more likely to be dissatisfied with their sleep compared to women who are premenopausal. So this is a national health interview survey that was conducted in 2015, where they estimated by a survey, taking into consideration, including women who are in the premenopausal, perimenopausal, and the postmenopausal group. Out of a total of 35.1% of the people who participated in the study, they found that the perimenopausal women were the highest who scored sleeping for less than 7 hours on an average in a 24-hour period. 40.5% in postmenopausal period, whereas it is much lesser in premenopausal, which is at 32.5%. The same study also surveyed on how often and what percentage of these women had trouble falling asleep for more than or equal to 4 times within the past week. That again showed a higher presentation among postmenopausal women, perimenopausal women, compared to the premenopausal women. The other aspect that was studied in the National Health Interview Survey was what percentage of women had trouble staying asleep for greater than or equal to 4 times in the past week. Again, postmenopausal women scored the highest. Next in order is the perimenopausal women, and low among the premenopausal women. Waking up feeling rested for more than or equal to 4 times within the past week. That again was pretty frequent among postmenopausal women, about 55%, perimenopausal 49.9%, almost 50%. Premenopausal is also high. And why is this? Because, as I said, women often need more time of sleep in order to feel rested compared to men. And non-restorative sleep is a common symptom that women report compared to the men in general. So that's probably why that non-restorative sleep has come up to be pretty frequent among the women. So how are we going to treat the women who come to our clinics with insomnia as their primary complaint? I want you to understand that cognitive behavioral therapy is always the gold standard treatment for majority of the patients who present to sleep clinics with insomnia, particularly if they have psychophysiological insomnia, sometimes even in patients who have menopausal-related vasomotor symptoms contributing to their insomnia too. CBT has been found to be helpful, including some cases hypnotic therapy as well through psychologists. But hormonal replacement therapy is a very interesting topic because there's so much of confusion and lack of clarity sometimes when we consider that. And so the basic common pharmacological treatments for menopausal insomnia include hormonal replacement therapy. In some cases, select cases, we do try hypnotics and sedatives and antidepressant, and again in some population. HRT is the primary treatment when the woman has insomnia secondary to the menopausal symptoms, which are usually the vasomotor symptoms of hot flashes and night sweats. Other medications that sometimes we use, but only on a short-term basis, not on a long-term, because of the consequences that come from long-term use of these agents. Zaloplan, particularly for middle insomnia, and short-term use again, and people with problems both with initiation and maintenance of sleep, zolpidem or Lunesta also have been shown to be effective. And just like any other group of patients, you have to always caution them about the sleepwalking and sleep eating, the non-REM parasomnias that are seen in patients in general who take the Z drugs. Women in the menopausal transition and postmenopausal women are also at the same risk for those conditions as side effects. Remotion is a selective melatonin receptor agonist that also has been shown to be of good efficacy. And I sometimes have chosen this in my practice compared to the zolpidem and Lunesta. And antidepressants, particularly in those women who are menopausal with insomnia and comorbid depression. So the menopausal hormonal therapy consists of estrogen and progesterone. Some categories of women need both the combination of estrogen and progesterone. Some need only estrogen. So it is women who have undergone hysterectomy that the menopausal hormonal therapy only is composed of estrogen alone. Whereas for women with an intact uterus, the most effective treatment for their vasomotor symptoms would be combination of both estrogen and progesterone. In most sleep studies, they have found that if you were to treat the menopausal vasomotor symptoms with hormone replacement therapy, it has been shown to improve their sleep quality by decreasing the sleep disturbances secondary to the vasomotor symptoms. As I said, some women have the vasomotor symptoms and the sleep disturbances affect their daytime functioning. So for them, it's really crucial improving the overall sleep quality. Menopausal hormone therapy in the form of low-dose estrogen and progesterone can also improve the chronic insomnia among menopausal women. And this is a meta-analysis study which was conducted by Atarian and his colleagues, published in 2015, where they looked at a good outcome, positive outcome in 14 out of the 23 research studies. Of course, there is variation in the types of the studies, the number of patients studied, and also the differences in terms of how they have defined the sleep disturbances in each institution and the parameters they used and all that. Complementary therapy. You will see day in and day out, there are some patients who have in their medication list herbal supplements, black cohosh, red clover, zinc, and isoflavones, phytoestrogens, and all that. So I'm going to talk to you a brief overview of how those complementary therapies work in these women with menopausal insomnia. About 40 to 50% of women in Western countries use complementary therapies to manage the menopausal symptoms, including the United States. Herbal tea, particularly those with chamomile supplement, has been tried in some research studies for up to 12-week period and has shown to have positive improvement in the hot flashes and sleep disorders, particularly those who had hot flashes as their primary complaint. Another product that is more commonly known is the red clover. It is an isoflavone, and it is an extract that can control the hot flashes frequency in the menopausal symptoms. And moderate improvement has been shown in some studies using the red clover as one of the herbal remedies. Mostly phytoestrogen supplementations like the soya isoflavones and chamomile, those sort of supplements, including the herbal remedies, have been shown to have modest reductions in the frequency of hot flashes and vaginal dryness, but they did not really show that much of an improvement in the night sweats. So again, these are not going to be like 100% the go-to, like causing complete resolution of symptoms. But people believe that they may not have side effects and it is not a prescription requiring. And some people have liking and proneness towards getting you comfortable using herbal remedies in general. But they have to be also aware that these compounds are not without side effects, particularly if they are made of compounds with some combinations which may be toxic. We do not know that. So we have to be very cautious in encouraging our patients to resort to herbal remedies. Acupuncture has been tried in some patients, and there are very few studies that show that they have been helpful. But again, it is not recommended treatment for the insomnia due to menopausal vasomotor symptoms. Coming to the antidepressants, we talked about some select patients with insomnia in depression can be treated using either SSRIs or the SNRIs. And if you take into consideration escitalopram, the Celexa, or the Lexapro, which is the escitalopram, it has resulted in 47% of reduction in vasomotor symptoms from baseline compared to 33% with placebo group. That's somewhat better. Venlafaxine has been more commonly prescribed even compared to escitalopram or paroxetine, and that has been shown to cause 47.7% of reduction from baseline in vasomotor frequency. Whereas FDA-approved medication, the SSRI, to control the vasomotor symptoms, and in fact had the highest probability of reducing the vasomotor symptoms, was paroxetine, but that is not commonly prescribed in practice, unfortunately. Duloxetine is another medication, the SNRI category, that has been shown to improve insomnia in menopausal women who have an underlying depression, plus vasomotor symptoms, anxiety, and also a subset of patients who have fibromyalgia, because this medication has been shown to have some improvement in the pain in these individuals with fibromyalgia. So Cymbalta or duloxetine has been shown to be effective in this select group of patients, particularly depression or fibromyalgia with coexistent insomnia. So the North American Menopause Society in 2015 came up with some recommendations, what to recommend commonly, what to recommend with caution, and not to recommend at this time. And some of those highlights are recommend cognitive behavioral therapy, hypnosis, and hormone replacement therapy in select population who have vasomotor symptoms as their primary cause of the insomnia. Whereas recommend with caution would be yoga, meditation, mind-body relaxation techniques, because they find that they are either inconsistent results with that, or there are not been enough studies that have shown that. But again, they say recommend with caution, but there is no negative side effect for women doing exercise or yoga. I highly recommend that for all people of all ages, depending upon what their body capacity helps or can do. I don't usually say with caution for that, but again, this is what the North American Menopause Society has come up with, including herbal remedies and herbal teas and stuff like that. What I do not recommend is weight loss as one of the strategies, because that has not been shown to be having any impact on insomnia in the menopausal women, unless there is a component of obstructive sleep apnea as a contributing factor causing the insomnia in these women, which is often weight related too, in addition to the loss of estrogen, progesterone, the hormonal deficiencies. So for them, for sure, weight loss would help. And again, I don't recommend for insomnia treatment, but I will recommend exercise and weight loss also for other aspects of mental and physical health. Restless legs is the other condition I'm going to talk after I've talked in depth about the insomnia. There are some women who develop restless leg symptoms exclusively only around the time of the menopause transition or the menopausal age group. So that means some of these women have never had this condition ever before. Also, there are some women who have had RLS in the past. It could have been pregnancy-related restless leg symptoms. They may have resolved after the delivery, which is usually the nature of the condition. But women who have pre-existent restless legs often have a higher tendency of developing restlessness in their legs, the RLS symptoms during the menopausal years. But as I said, some can develop exclusively in this age group. Sleep disturbances are very common among these women who have restless leg syndrome. Treatment is often challenging, just like with any other age group where we control the RLS symptoms. And hormonal replacement therapy has been tried. In fact, there were some research studies where they found that under the influence of hormone replacement therapy, there was increase in the PLM frequency, but they did not show any significant impact on RLS symptoms. And the RLS symptoms in the menopausal women have a very strong correlation with serum iron status. So when you are doing the iron function test, I would just not do ferritin alone in these women. I would do the complete iron panel, which is serum iron, the iron binding capacity, percent saturation, everything in detail to completely assess, because some of these women have other comorbid conditions. So it is good to do the complete panel. And of course, the recommendation is the same as any other category of RLS patients. The goal to have the serum ferritin reserves greater than 75 nanogram per milliliter. The pharmacological treatment for restless leg syndrome. This is a very detailed slide that was published in 2019. This talks about the different categories. So again, this is the same as we use for any other RLS patient. But to highlight what has been approved, and the first line of treatment is the delta 2 ligands, which is gabapentin, pregabalin, and pregabalin has not been approved for pharmacological treatment of RLS in the menopausal women, but it has been used. I have used it in our patients who have RLS symptoms in different age groups, including some of the menopausal, though it is not approved exclusively for this age group of patients. And gabapentin anacarbon has been approved. Ropinirole, rotibutine, pramipexole, all have been improved, but again, we have to be always cautious with these dopaminergic agents because of the risk for augmentation. So just like with any other patients with RLS, in addition to the pharmacological treatment and checking the iron and iron supplementation, non-pharmacological treatments are very essential in conjunction, which would be reducing the caffeine intake and avoiding caffeine within 6 hours before bed, avoiding alcohol within a couple hours before bed, smoking cessation, exercise, good sleep hygiene, treating the underlying medical conditions like iron deficiency anemia, diabetes has to be controlled. If they have an underlying hypothyroidism, that has to be optimally controlled, because all of those conditions can also impact RLS symptoms because of the comorbid association. And ice packs or warm blankets, depending upon what they feel comfortable with, warm bath and massage, all of these things are also very important remedies that people have to consider, particularly when they start having symptoms in the daytime. We do not want to consider adding another pharmacological management in the daytime. So being active during the day and these non-pharmacological measures will be very helpful for daytime symptoms, as long as they are mild and not affecting their daytime functioning. The next sleep disorder I'm going to talk to you about is obstructive sleep apnea. As we all know, men have a higher prevalence of sleep apnea compared to women. However, the prevalence increases among the women who are menopausal. And once the menopause occurs, the prevalence is almost equal in men and women both. The Wisconsin sleep cohort, which is a very old study and a very robust study, the odds ratio for moderate obstructive sleep apnea increases from 1.1 in premenopausal state to as high as 3.5 in postmenopausal women. The prevalence of OSA in menopausal women can range from 47 to 67%, and this is way high compared to premenopausal women. What are some of the potential risk factors contributing to obstructive sleep apnea among these women? It's the weight change. The weight change could be secondary to hormonal changes with the decreasing estrogen and progesterone. It also could be lifestyle changes, sedentary lifestyle, or other comorbid conditions that can preclude their exercise ability, and some dietary changes and stuff that can cause the weight gain. They also have been shown that sometimes women may have some collagenous deposition in the menopausal transition in the subpharyngeal areas or the subglottic areas. Sometimes that can also contribute to some anatomical obstruction causing sleep apnea. If we consider obstructive sleep apnea and RDI, which is the respiratory disturbance index, where we also add the respiratory effort related arousals, women who are premenopausal and menopausal have a lot of RERAs more frequently compared to men. And loss of progesterone also increases the tendency for collapsibility of the upper airway muscles. And progesterone, as we know, is a very good respiratory stimulant. So progesterone hormonal loss is one of the major factors causing sleep apnea in these women. How are we going to treat the obstructive sleep apnea in the menopausal women? The treatment is the same as with any other population. CPAP in mild, moderate, or severe cases, particularly moderate to severe with hypoxemia and other comorbidities, particularly if they have a coexistent cardiac condition. CPAP would be very safe and very effective. Or BiPAP, depending upon the sleep study findings and their coexistent hypercapnia, obesity-related hyperventilation, those sort of conditions. There are non-CPAP options too, that some people, not everybody wants CPAP, as we all know. So weight loss is for everybody and all age groups. Positional, if there is a positional component, using special devices like the Zoma pillow or other options. Dental appliance is still a viable option, particularly if you have mild to moderate sleep apnea, which is position dependent in the postmenopausal women. Surgery, unfortunately, is never the first line of treatment. Though in select population, there may be some patients who may want to go for procedures like hypoglossal nerve stimulation therapy, the Inspire implant, but you have to fail the trial with the CPAP or intolerant to CPAP, and you have to have certain parameters in your sleep study and during the drug-induced sleep endoscopy to be determined as candidates for that procedure. But the most common ones are CPAP, dental appliance, and positional therapy that are commonly used in these patients. The oral appliances, there are different models. And again, we recommend custom made through dental sleep medicine practitioners rather than over-the-counter ones. And this is the hypoglossal nerve stimulation therapy. This is a slide where this is the obstructed airway, and look how it is at the base of the tongue. And after the stimulation, how much opening happens at the base of the tongue and at the palate level. Look at the degree of obstruction and look at the improvement with the hypoglossal nerve stimulation, that there is improvement in the overall severity of sleep apnea by the procedure. Fibromyalgia is another interesting topic, which is very common in this women group, the menopausal women. That is a very important factor contributing to insomnia, apart from the vasomotor symptoms. So fibromyalgia predominantly affects 80 to 90% of the women and they all have sleep disturbances. Mostly it is insomnia. Now, what are the changes that you may see in these patients when they undergo a diagnostic polysomnography in the lab? They often have decrease in stage N3 sleep. They can have sleep fragmentation, lots of arousals. Some of them can also have cyclical alternating pattern, which usually is a representative of sleep state instability, commonly occurring in the non-REM sleep. They spend more time in stages N1 and N2, which are lighter sleep stages. And of course, they will have reduced sleep efficiency because of the pain and other factors depending upon what's going on. The common thing that you sometimes see is an alpha delta phenomenon, in addition to the increase in cyclic alternating pattern in the polysomnography, the EEG part of the studies. The alpha delta phenomenon is when they are in their N3 sleep, you would be expecting to see delta waves, but you will see lots of intrusion of alpha waves, making a confusing picture for scoring the sleep staging. But there is a sign that is seen commonly in these people because of their sleep disturbance and their sleep stage instability with the arousals and all that. But it is not required as a clinical diagnosis. It's not like one of the diagnostic criteria. It is one of the findings that we commonly see, because we can also see the alpha delta phenomenon on the EEG in sleep studies of patients with chronic pain syndrome too, not necessarily menopausal or not necessarily fibromyalgia. How are we going to treat the fibromyalgia? The drugs for pain management in the fibromyalgia patients, which is FDA approved, are pregabalin, duloxetine, milnacipran. Out of these, pregabalin and duloxetine are commonly prescribed. We have seen that when you compare pregabalin and duloxetine, pregabalin may cause some more drowsiness and sedative properties compared to duloxetine does. And the advantage of duloxetine would be also in a person, menopausal woman who has insomnia with fibromyalgia and coexistent depression or anxiety. However, the drug that we usually don't commonly prescribe, but here and there you see this medication in the medication list of the patients we see in the clinics, amitriptyline. That has been very extensively studied for the treatment of fibromyalgia with some improvement in pain, fatigue, and sleep. Of course, all the pharmacological measures would always be accompanied by non-pharmacological measures, because they, in conjunction with medications, are more helpful. So some of the non-pharmacological interventions that have been helpful in managing the insomnia due to fibromyalgia in the menopausal women include CBTI, exercise, weight-bearing, non-weight-bearing exercises, swimming, water aerobics, aqua jogging, hypnosis, yoga, massage, and all of that. Now coming to the other aspect of depression, we already spoke in the previous slides that women who are menopausal have hormonal changes that can contribute to depression and anxiety. And we also know that the depression during the menopause can be associated with insomnia. So the menopause transition is a risky period when women often tend to develop more depression and they need to be treated. So the common factor in the relationship between menopausal transition, menopausal symptoms, and depression is the hormonal changes that occur during this period. So what is the prevalence of depression during menopause? Again, there are some studies that I've highlighted. For time purpose, I'm going to talk on the most important study, the SWAN study. 3,302 women studied in this category showed that as women progress through the menopausal transition, depression scores were higher in the menopausal women, independent of demographics, psychosocial, and behavioral factors. So the demographic factors, white ethnicity, low educational level, psychiatric, coexistent, comorbid, or pre-existent depression, anxiety, psychosocial, stressful life events, low physical functioning, and menopausal related severe persistent vasomotor symptoms, greater hormonal fluctuations during menopausal transition, early menopausal age or surgical menopause, which drastic hormonal changes. All these things can be contributing to depression among these women. How are we going to treat them? Antidepressants are the first line of treatment for moderate to severe depression that occurs in menopausal transitional period. Both SSRIs and SNRIs have been shown to improve insomnia, particularly those causing the hot flashes, particularly as a contributing factor for the insomnia. There has been improvement in the mood with estrogen replacement, but it is not considered, the hormone replacement has not been considered as a treatment of depression per se. It is specifically for hormonal related vasomotor symptoms. And estrogen replacement can be used in some patients who have depression if they have the vasomotor symptoms, not just by depression alone. And of course, cognitive behavioral therapy used in conjunction with pharmacological measurement is the gold standard treatment. And there have been several studies that have shown that CBT has been effective in controlling and managing the insomnia in these patients with long-term benefits as well. Well, that was the short version, as much as I tried to consolidate the topic because it's vast. I could talk more, but I thought those were the key things that we all need to know as sleep providers. With that, I conclude my talk. Thank you all for attending. And I would like to open for any questions.
Yeah, hi, I think we have a question here. So I just wanted to know at what level of iron do we start treatment? I think ferritin is 75 is the cutoff, but is there like an iron level that menopausal or ferritin, the cutoff in terms of treating?
For the restless leg syndrome, you mean? The
menopausal women.
Yeah. The restless leg symptoms, the management is just going to be same as any other category, any other population group. You want the ferritin level greater than 75 nanogram per deciliter.
75, okay.
75 is still the same thing that is used because remember, these patients, particularly the women who have restless leg symptoms, which has started around that age group for the first time, particularly the first-time developers of RLS symptoms in the menopause age group, are often very challenging to treat. And in them, the restless leg symptoms are very, very closely associated with iron reserves, the serum iron reserves. So you have to make sure that you would be able to manage by the iron supplement. And again, some women, if their levels are really low and they're very symptomatic and refractory to treatment, you would consider the same decision and judgment about IV iron infusion, just like with other RLS patients.
Thank you.
Thank you.
Yeah, and Natalia Baker, thank you for attending the talk. Natalia Baker is one of our sleep fellows, and she is wondering what dose of progesterone do you recommend for insomnia? So Natalia and others, like the progesterone is not really recommended for insomnia alone. It's basically a recommendation of hormone replacement therapy in people who have insomnia, in addition and more secondary to vasomotor symptoms, not just insomnia alone. And the low dose micronized progesterone is all what would recommend. I don't know the real strength of the medication, but it is very low dose of the progesterone that is used in these patients. And again, you have to remember to give it in conjunction with estrogen when you're considering progesterone for women with intact uterus. Tala Kazmi has another question. Is there any time duration that we like to continue HRT for patients with insomnia, keeping in mind the side effects with prolonged usage? Yes, definitely. Because there is like select population, before even you consider the hormone replacement therapy, we have to check with them, is there any contraindications, absolute or relative? Do they have any underlying thromboembolic conditions or concerns with cardiovascular disease? Because these are very well, or breast cancer history. So you have to be very careful in selecting the patients on whom you're considering the HRT. Usually when we do the HRT in our institution, we consult the gynecology provider as well. So it is like a multidisciplinary approach that we go with. And we often recommend the HRT only for a short term, because the benefits that come from the HRT also in this menopausal people, particularly if you're looking in terms of cardiovascular disease risk and all that, it is more beneficial only around the menopausal age group. It's not going to be as much helpful after you're 65 or 60 or something. So 45 to 60 would be the most common age groups that we would consider, again, not long-term, short-term. But again, it is very hard when you wean them off. You have to gradually do it. And gradually, even if it is a patch-like preparation as opposed to an oral supplement, you have to make sure you taper it gradually, because oftentimes you'll have rebound insomnia in these patients, and they also report fatigue. Some of the patients I have had in my clinical practice. So you have to do that in conjunction with the multidisciplinary approach, talking to the gynecological provider for the patient.
Thank you very much.
Any other questions? Of course, if you come across any questions, Sally has my email address. It's pusal001@umn.edu. Feel free to email me and I'll get back to you.